In this video, everything you need to know about insulin resistance, what it is, how it's so important, and what you can do to fix it.
Welcome to this channel. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please subscribe and hit that notification bell.
Hello everyone, welcome to the TRT and Hormone Optimization YouTube channel. I'm Danny Bossa. Today's guest, Dr. Brad Garner from Mercy Clinic Aurora. Am I getting that right?
Yeah, that's right.
I'm sorry about that.
Yeah,
Today's topic is going to be about all things insulin resistance. We haven't done a video on that before. And that's a topic that's often ignored, why some of these teen mills that are just pushing testosterone, they won't really do anything about optimizing thyroid or optimizing anything regarding insulin resistance. So we're going to talk about that today and how that can be helpful for you guys on TRT, even those of you who's not on TRT, just to keep those things in check. Brad, what do you got to say on the subject?
well, thanks for having me, Danny. Actually, that the insulin resistance is how I started down this wellness optimization road with my own patients. Actually, um, several years ago, became frustrated with what was going on with my patients and not improving their health with the standard guidelines. Started to take more of a root cause approach to medicine. And if you look at most of the disease that our patients are dealing with on a daily basis, honestly, insulin resistance is either a primary driver or a significant contributor to almost all of those things. So frequently think about it in relative or in relation to diabetes, but it also is involved in high blood pressure, Alzheimer's disease. There's even some literature that indicates it may be involved in the development or worsening of prostate enlargement. Clearly, PCOS for women, it's a big deal. Fatty liver disease. So there's just a lot of different areas where we would see that. And there's a very strong association with that and low testosterone. And so as we start to kind of look at all the different areas to optimize, given the fact that insulin is in fact a hormone, and it makes sense to try to optimize really what I would consider to be the mother of all hormones in insulin, in that it drives so many metabolic processes that if you don't address it as a part of your life strategy, optimization strategy, I think really we end up kind of falling short of our goals. It's kind of like trying to drive a car with three wheels. It's just not going to quite get where we want to as well. And I think what's interesting is that whether you're talking about general health practices or performance, I think there's a lot of parallels and a lot of crossover between the two things as well, in terms of optimizing insulin. The problem is with insulin resistance is you have essentially an energy toxicity problem. So the fat cells or muscle cells as well, but essentially the fat cells begin to store too much energy in the form of uh, basically fatty acids in different storage forms, and they are input from dietary fats and from carbohydrates that are stored then as dietary fats and glycogen. Basically, what happens is insulin is used to signal to the cell that glucose is available for transport, and it transports it into the cell through different cellular mechanisms because it doesn't want to have extra sugar floating around in the bloodstream. And so basically, when you have the extra sugar floating around the bloodstream, insulin attaches to a signal and then or to a receptor, and then it takes in the glucose. And that's how our blood glucose is, for the most part, managed and stabilized. Um, well, that process is happening essentially all the time. Through gluconeogenesis, our liver is making glucose at a pretty steady state. Our pancreas will make insulin at a pretty steady state to keep that suppressed. Well, basically, the problem with our standard screening for type 2 diabetes is that we look only at a glucose level. And so we're waiting for the glucose to become abnormal before we diagnose diabetes or prediabetes or even insulin resistance for that matter. When in reality, there's data that shows that the insulin will become dysregulated sometimes as much as 30 years prior to the glucose meeting criteria for type 2 diabetes.
Mm.
And so we started using fasting insulin in our practice about 4 years ago as just a screening tool for everyone, because you're able to actually identify folks that have insulin resistance or hyperinsulinemia long before their blood sugars become abnormal. And that really allows us to be much more aggressive in terms of intervention. And so for the guys on the channel and for the ladies, when they're looking for screening lab work, I think it's really, really important that you not just look at fasting glucose, but even the A1C, because both of those are just glucose numbers. Actually request a fasting insulin, and also look, just like we've seen with testosterone, the reference ranges aren't always the whole story. And with the insulin, frequently what you'll see is they'll say a normal insulin value is between 2 and 24, when actual optimal fasting insulin is less than 5. And so frequently I'll have people that have seen other providers and they've had a fasting insulin of 20, and it falls within the reference range, and they'll say, well, they checked my insulin and it was good. And in fact, it wasn't. And oh, by the way, they also had neuropathy that no one could ever figure out what it was from, and they also had high blood pressure and erectile dysfunction, because they essentially had diabetes. There's a paper published, it's been a few years back, that really indicated that hyperinsulinemia or elevated insulin, even in the presence of normal glucose, will contribute to the development of vessel disease in the coronary arteries. So there are some people within the insulin resistance field that really feel like that a lot of the pathology that we see from diabetes is from the elevated insulin levels rather than the glucose alone. So I think that it's really important that we check that. And we know essentially, I mean, from the bodybuilding world, I mean, guys use insulin for, trying to get size. And basically that's what insulin does, is it tells things to get big. And so it tells the cells to get big. And as those cells get bigger, they run out of space. And, an analogy I like to think of is, basically if you've ever been in Asia, when I was in the Army, I was in Asia for a year, and you're on the subway and they're trying to stuff people in the subway. They're trying to push them in the doors, and they've got the pushers and everybody. Well, that's essentially what's happening with glucose and insulin. Insulin is trying to clear the subway ramp of everything, and it doesn't matter whether it's just got to get it out of there. So it's shoving all the stuff inside the cells, and eventually you reach a capacity at which it can't do it, and so it just basically is starting to produce more and more insulin, because the pancreas recognizes we still have all this glucose, we still got to do something. So it starts to rise and rise and rise. And the problem is that insulin doesn't just cause hypertrophy of muscle cells; it also causes hypertrophy of fat cells. And so that's really the issue. In addition to the fact that one of the other things that it does is it shuts off fatty acid oxidation. So basically, it's like a dam. So once it gets it in the cell, when you do have an energy deficit in terms of calories or whatever, your body tries to extract it from the fat cell. Well, there's an enzyme that does that process. It's shut off basically by the presence of insulin. And that's really a survival mechanism. I mean, essentially, we're designed to survive feast and famine, essentially. And so when insulin levels are elevated, our body is set up to allow the storage of fats for a time that we don't have foods. And basically, we have ancient DNA in a current eating environment that is really a mismatch. And so we have constant insulin stimulation. And so that just sets up a constant time of storage. And so we're eating for winter all the time if we don't really pay attention to what the insulin levels response is to our food. And so basically what we try to do is help people identify the things in their diet that basically have a high insulin load, because that's going to be the most effective way to lower the insulin level itself. And when you do that, you identify the high insulin items, and then you replace them with low insulin items. And that is a way that you can directly lower the insulin. And then what that does then, by lowering the insulin, it obviously decreases the inflammation and all the things that go along with the vessel disease. But then it allows for the process of fatty acid oxidation to take place. And so, because while, it's true that and one of the things that I've seen in the group on Facebook when we've talked about insulin resistance, and there's been different posts about, macros and different things as far as dietary stuff goes. It's interesting, forever it's been calories in, calories out, eat less, exercise more. That's the way that we need to do this. And then there's another camp that says, okay, well, obesity is primarily an endocrine related issue. It's hormone related, and that's the issue, and calories don't count. Well, I would argue that they both are true, in that you have to have some type of energy deficit or need to dip into your fatty acid stores inside the adipocytes. So, but you can't do that very effectively if your insulin level is very high. That's part of the physiology of how we're doing it. So both things are true. It is true that energy matters, and that energy is in the form of carbohydrates and fat. I mean, both of those things are energy forms that protein is not. And so basically, both fats and carbohydrates are essentially carbon-carbon bonds that are stored energy. And when they're taken in dietary form, they can't be used as fuel immediately. So generally, they just get put into various types of cells. Once that spills over, basically, once it gets over full, then we start to see triglycerides form. And that's part of the reasons why people would see elevated triglycerides, in someone that has insulin resistance. So that leads to one of the other things that we look at. If we can't get a fasting insulin level, we'll look at the ratio of triglycerides to HDL. And so if that ratio of triglycerides to HDL is greater than 2-to-1, then there was a study done in California by Kaiser looking at their group, folks that have had vessel disease. And that increased the risk, that ratio increased the risk of insulin resistance by 17 times. So it's a pretty significant thing. The interesting thing is that when you go after the low or the high insulin items in the diet, you see a dramatic drop in triglyceride levels, a huge drop. And that's because you've lowered the insulin and you've allowed basically the adipocytes to shrink, creating more space within the cells and improving the insulin. Because essentially adipocytes really don't go anywhere unless they're surgically removed. So they either just shrink or they grow, or shrink or grow. That's basically how that goes. There's a few exceptions to that, but for the most part, that's how it goes. And I think, in the context of optimization, we all like to think that we're exceptions to physiology, or we all like to think that, I think guys in general like to overestimate how intense their workouts are, and we underestimate how we eat. And so I think it's important, whatever we're doing, to be realistic with ourselves and say, you know what, I actually probably should do some things that are different, because I'm not this guy on the cover of the magazine. I'm not, there's some things that I have to address. And I think that's where some of this kind of overlaps with just general health optimization, because all of us that are here in terms of trying to optimize hormones and all these sort of things, essentially what we would like to have, I would assume, is the most amount of lean mass possible and the least amount of fat mass possible. And it turns out that actually is a very healthy way to live, just in general, whether you want to look good or you just want to live good. And so that is a way to do that, is to look at how much excess energy am I taking in the form of carbohydrates and fats, and then how is that affecting my insulin? And if my insulin level is elevated, then I have to do something to change it. If I don't, that's fine, but I shouldn't expect to get the full benefit of all these other things that we talk about on the channel. Because I have patients all the time that we'll get everything dialed in. We'll get thyroid dialed in, we'll get testosterone dialed in, and they still are obese, and they still are tired, and they still are, all these types of things. And they're thinking, well, I just need more of, whatever. I need more testosterone, or I need more thyroid, or well, no, you need to fix your insulin resistance. That's just how it is. I can give guys all the testosterone in the world. They could take a shower in it, but if they're eating a donut in the shower, it's not going to fix anything. So it really is important to be realistic about that and have a good perspective on it. And I think the thing that's very interesting is that protein is just amazing in terms of its ability to do that. And there's a lot of good evidence that protein, if you use it as your main focus in your diet or your target, it is super powerful. It has its own thermic effects, and so it increases your metabolism. What's interesting is that there's a guy named Ben Bickman who is a PhD researcher in bioenergetics at BYU. He's super fascinating. If you ever check him out, you should. great communicator. But he's talking about insulin resistance. He has a paper that's going to be published in not too long from now. But basically, when people lower the insulin levels, they will access the fatty acids for fuel, and that's where ketones are produced. And ketones are the alternative fuel that your body can use. And literally every tissue in your body can use ketones for fuel, with the exception of erythrocytes or red blood cells. Those require glucose, but the amount of glucose that they require can be produced by your liver. So it's not something that has to be taken in dietary wise. So Ben Bickman has a paper coming out in not too distant future, but basically it looks at those ketones actually increase what's called mitochondrial uncoupling. And so basically it increases the metabolic rate at the cellular level in adipocytes. So it actually upregulates at the same caloric value, it upregulates the metabolism when ketones are present in the adipocytes. So it's really fascinating, and it does the opposite in skeletal muscles. That actually improves their efficiency, but it doesn't uncouple them. So they actually grow and it burns the fat cells. It's really super interesting data. So I think,
is this very quick, Brad? Is this something that's achieved simply by adding more protein to your diet, or is this something that's only achieved if you achieve ketosis by having very little carbs?
Yeah, no, that's a great question. So there actually are some data that looks at if all you did was add additional protein to your diet, you would actually improve lean mass. There's some studies that look at that. To get the full benefit of that, yes, you would use protein to displace the high insulin items. And interestingly, how much carbohydrate restriction you need is really dependent on context. I think just like when we talk about, a lot of things within the hormone world, you talk about, well, what are your goals and what context are you working with? So if you have someone who is really close to their ideal body composition and has a reasonably active life and works out and stuff, and they probably could get away with a significantly higher amount of carbohydrates than someone who has a BMI of 45. And is not, and would still be able to do it. And they would be able to, the leaner person would be able to achieve the same amount of benefit with a significantly higher carbohydrate amount. The other thing that's interesting is anything that lowers insulin really should be the goal with dietary inputs. So, while restricting carbohydrates is important for that, also restricting energy in the form of additional fats would be helpful as well, because while you're not directly decreasing the insulin, you're going to be forcing the body into a slight energy deficit. So then you're going to use fat for fuel because you're going to have to extract that anyway. And so that you'll shrink down the fat cells and improve sensitivity. So there's a lot of things there to look at. And I think that, if you add protein to displace the other basically things like fats and carbs that are only purely for energy, you're going to see some improvements. The other nice thing is that protein has a significant satiety factor that doesn't really exist with carbohydrates. In fact, there's something called the protein leverage hypothesis that basically we were designed to seek out protein sources primarily because they're really nutrient dense, and except for plant protein sources, which is a different conversation. But animal protein sources are really nutrient and energy dense. And we have this sort of innate drive to seek out those sources. And that's part of the reason why it's easier to overeat a dozen donuts than it would be a pound of bacon, because you essentially, there's very little protein value there, but there's a ton of energy. And the chemical structure and the way that the fats and carbohydrates interact with our brain elicit a response with dopamine that will then drive further eating, basically. So the proteins themselves, if you pick things that are leaner and have a greater protein content, then you tend to be satisfied sooner. So then you have a tendency to overeat less. And that's actually part of the reason why low carbohydrate diets work well for a lot of patients, just because there are a lot of different inputs in terms of why we eat, and whether that be habit or hunger or energy needs or whatever. And a lot of those boxes are checked by lowering the insulin via the carbohydrates. People can lose weight for sure doing a very low fat diet, there's no doubt. But you can't do high fat and high carbohydrate and expect to lose weight. I mean, it just doesn't work that way physiologically. You have to give on one end or the other. And if, you know, calories in, calories out, if that were true, we wouldn't be able to see the improvements with glucose uh, that we see with testosterone. So the GLUT4 receptor is the one that insulin basically stimulates to moderate blood sugar levels. Interestingly, testosterone does the same thing. So it's just an example of how hormones will affect the the glucose and insulin level, thereby affecting the metabolism and all that. So I think that that in and of itself, for folks that are familiar with testosterone, should show us that yes, calories matter, but they're not the only thing that matters, and that there is an endocrine component to maintaining a lean body mass that really we can't ignore. So yes, someone could eat 300 grams of carbs a day and lose weight, but they would have to do it in a way that would also lower insulin. So it would require probably a significantly higher energy deficit than it would if you remove the carbs and replace those with more protein.
Gotcha.
Because the protein essentially is a wash when it comes to energy value for carbs as far as calories go. The interesting thing is, though, it is the complicated molecule for our body to break down for fuel. So it requires 5 ATP to generate energy from protein when carbohydrates are 2. So it's just not the easiest thing for your body to use for fuel. So it's just not going to do that unless there's literally no other option. So, well, yeah, it's a pretty interesting thing. And with my patients, I think it's something that has been really helpful to them for us to sit down and talk about, because it can drive a lot of frustration, because I think, they're expecting testosterone or thyroid or whatever to do all these things, and they really don't get the dietary part, and it doesn't really cut it. And there's a lot more sort of detail and things that we can get into, and some of the different stuff. I mean, structuring dietary stuff is kind of what I do a lot of, and it's pretty fun, and it's very, very patient dependent, but always with an eye on what is this going to do to my insulin level, because it's clear from both epidemiologic studies, which we know are not great, but also with the physiology that's there, that insulin is a big driver for disease. So we have to go after that if we're going to really make a good effort at fixing the things we deal with.
Couple fast questions. Why do you think it is that most doctors are just measuring, blood sugar, blood glucose, and aren't using this other method of, let's just check fasting insulin, or let's check the ratio of triglycerides that you brought up? It seems like those are a much better indicator. Why are you just stuck on the whole blood sugar, blood glucose stuff?
Well, I think it's the same problem we run into in a lot of other areas of medicine, where, the guidelines say, from the American Diabetic Association, American College of Endocrinology, that you have to have a glucose of 125 2 times, and you have to. So basically, all the primary organizations that set out guidelines have really just looked at glucose as the driver for disease. And honestly, for the last probably 50 years, there's always a voice in the wilderness that has said, "Hey guys, this is probably not the thing that we need to do," but there's a lot of inertia to overcome that, and so. You'll have these expert opinion based guidelines, which is essentially what most of them are, that are really kind of running the show. And so, they basically don't get a voice in that setting. And so that's why a lot of them do it. And a lot of them don't really fully understand. And like, we've talked about with the reference ranges, and I mentioned before with the insulin, the reference ranges for testosterone. I mean, people just look at them, and if it has a flag on it, then we say something about it. If it doesn't have a flag on it, we don't. And, it's all good. But the reality is there's a guy, his name is Joseph Kraft, and he was a pathologist. He wrote a book looking at this specifically, and it's super fascinating. It's a really quick read. He actually studied the blood work of 15,000 patients, well, close to 15,000, and looked at basically as a pathologist, he looked at the vessel disease, he looked at their previous lab work, he looked at a lot of different things, and was able to delineate out an insulin release pattern. Basically described 5 different insulin release patterns that was pathognomonic of diabetics, and it's super fascinating work. And So basically what he did was he actually took patients, and when ladies are pregnant and they do the glucose tolerance test where they drink the sugar and then they check them and all that. Well, he did that, but he did that plus checking insulin at each interval. And the patterns are really fascinating because the patients, basically, you could see there's 5 different patterns, and some of them were very smooth curves, and then some had a normal fasting level, but it just really spiked super high. Well, what he found is that 75% of the people that had an abnormal insulin release pattern had a normal glucose, but still had pathology related to diabetes on their autopsy. So it's really fascinating, and that's why I think looking at insulin is really, really powerful. So clinically speaking, if I have a patient that for all the world looks like diabetes, and their fasting insulin level is still at that level of 5, because in fact, I saw a guy this past week that his A1C was 16, which is atrocious. And I mean, because a normal non-diabetic A1C is less than 5.7, so it was pretty terrible. But his insulin was 2, and so theoretically that should be an okay insulin level if screening with the fasting insulin was the only way to do it. But the more likely thing is he has a fasting insulin that's more consistent with one of these late release patterns that were described in the literature. And so he still has significant insulin resistance. He just has a different release pattern. So I think that using the fasting insulin is very, very effective for folks in general, but there's still going to be some exceptions to that, like everything. And so using, judgment and looking at it and being honest with ourselves. I mean, I think a lot of times guys, will say, well, that's not me. I don't have that issue. I'm not morbidly obese, whatever. But the reality is it doesn't discriminate. I see it every day. Thin looking guys that otherwise are healthy, and they have terrible insulin. I saw a guy last week who was transferring care to me from a different provider, and he was a brain injury guy and all the stuff that I love to take care of, and had been on testosterone for a while. But his triglyceride to HDL ratio was like 12, and we wanted to be less than 2. And I mean, he looked jacked. Like he was not like he did not look like something was wrong with him. And it is very clearly metabolically wrong. And so I think too often we want to sort of just ignore that part of it and think, well, again, I'm not morbidly obese. I don't have these issues. It's not going to be a problem. And then those are the guys that will end up having heart attacks. And then somebody will say it was their testosterone that did it. I mean, that's just, that's kind of how that plays. And so I think we have to be wise about it, not only for ourselves, but for the community, because if we don't take care of those sort of things, it makes everybody look bad when we end up having disease that is totally unrelated, but everybody will say it's not. So.
What would you say of the guys you do check for this type of thing? If I was just to give you, I'm not going to hold you to this number, but
okay.
A random percentage of all the patients I have, what are the percentage that have issues with insulin resistance?
Yeah, that's a great question. Recognizing there's probably some selection bias because I've got people that are coming in that are sick. I would say it's probably up north of 90% of the guys I check. Oh. I mean, it is crazy. I mean, statistically, if you look at just from like the World Health Organization and all this stuff, I mean, they're already saying that at least a third of the population has type 2 diabetes changes in their blood sugar. So that's not including what I'm talking about as far as insulin resistance, because what I'm saying is the data shows that if we check fasting insulins, we'll capture a larger group of people. And so now when you include that understanding and then the selection bias, yeah, it's huge. It really, really, really is huge. In fact, I had insulin resistance before I started eating the way that I do. And that was several years ago. And I was always an athlete. No one ever asked questions because I was always, in good shape or whatever. But I had a ton of intra-abdominal fat, and that's where it hides out. It'll be inside the abdomen and around the liver and the heart, and it'll get you. It doesn't care. You might as well weigh 500 pounds when you've got that. I mean, it really is exactly the same. I think that folks in that situation are actually at a much bigger risk because they don't have the social pressure to change. Everybody knows that guy that can eat whatever he wants and never apparently gains a pound. Well, the problem is that those people, more often than not, I mean, there's going to be some exceptions, but if you live your life thinking you're going to be exception forever, you're going to get in some trouble. More often than not, those guys are going to have significant vessel disease because of the insulin response to the types of things that they're eating. and we just can't overcome it with exercise. It's really unfortunate. You know, we see examples of this all the time. I think there's a lady that swam across the English Channel a few years ago, and I mean, she set the world record like 6 times in a row or something crazy. And obviously, she had to train a lot to do that, and she was obese. You know, it's there's all sorts of examples of people who are at the height of athletic achievement and very physically active and are morbidly obese. And you know, and the other example that I like to use is if you know the difference between what a power lifter looks like, or like one of those strongmen versus a bodybuilder. I mean, they both work out a ton. I mean, there's no doubt that they do, but clearly one is much more lean than the other. And the primary difference is not, you know, how many reps they're doing and all that. I mean, there's tons of studies that show that. It's really, it's their diet, it's their input. I mean, you can't out eat or out exercise a bad diet. It just doesn't work.
And are you primarily fixing this with your patients by dialing in their diet, or are you using things like you know, berberine or metformin? You know, what are your thoughts on those?
Yeah, so it is primarily diet. I do use metformin. I do use berberine some, but usually it's in the folks that, you know, would prefer to not use a prescription, or, you know, they have GI side effects from metformin. But generally, that's what it is. I have a few people that there's some medications for type 2 diabetes that don't disrupt insulin. They're called GLP-1, and so they have the side effect of weight loss. And so if someone has insulin resistance, I'll use those temporarily to help them kind of get over the hump in terms of trying to get things better. That is another point I wanted to bring up. A lot of the medications we use with type 2 diabetes actually make the insulin resistance worse. And basically what they do is they use the approach of, we've got to get the blood sugar lower no matter what the cost. And so we'll, you know, basically either inject insulin, or we will give what are called sulfonylureas, for example, and those actually increase production of insulin. Well, you know, we just talked about earlier how high levels of insulin have been shown to cause all sorts of inflammation and vessel disease. Well, if I get your blood sugar lower by purely just increasing the amount of insulin you produce or adding it to the system, I'm only making you sicker. Like, we'll pat ourselves on the back because your blood sugar looks better, but you'll get sicker. And so I've really changed how I manage type 2 diabetes in that respect, because I don't use those types of medicines anymore. And what's really interesting, and physicians know this too, anytime you start a type 2 diabetic or even type 1 diabetic on insulin, or change their insulin dosing, they gain weight, because that's what it does. When insulin levels are higher, everything gets bigger. And so, you know, so that's what we try to avoid, is because when those get bigger, you get worsening insulin resistance, and it just kind of continues the cycle. So yeah, we use the metformin, we use some of the GLP-1s, but it's primarily some dietary input. We do optimize the thyroid. You know, for a lot of folks, that's not going to be like the be all and end all. You know, hey, you're having trouble losing weight, and I give you the thyroid, and then everything falls into place. But it does tend to, for folks that have done everything else, it does sometimes end up being that last part. And the interesting thing about the thyroid is that the insulin resistance affects it as well. Because when you have insulin resistance, your cells think that they're starving, basically, because they can't get fuel. And so they downregulate the conversion from T4 to T3. And so then you basically can manipulate the TSH number all day long with a T4 and all that, but you can't get the good benefit, actual symptom-wise, by using just T4. And most people have insulin resistance because they don't process it well. So you can drive the TSH into the dirt, and they'll still have a low T3 because it's not working. Your body says it's not going to do it. So we'll use that too, and you know, I'm all about using all the different tools, but at the end of the day, the bulk of the work falls on the patient.
Yeah, there's a lot of guys that are, you know, they claim, you know, everybody should be on metformin. It's a wonder drug. Yeah. It's a drug, and everybody and their mother should be on metformin. So you're not really of that opinion, I guess.
I'm not. You know, when we started doing the dietary stuff several years ago, we saw so many improvements in folks without any medicine. And so when I saw that, it really, I mean, because most people, and this group is a little bit exceptional, because a lot of the guys, the goal is to optimize by pretty much any means necessary a lot of times. And so it's a little different. But a lot of times on the clinical side, folks don't want to be on medicines. And so if they can do something to be off of them, then they will. And so I try to take that approach first. And then if we can't dial it in, then yeah, we'll do it. Or if I have someone that weighs, I saw a lady last week, she weighs 420 pounds. And so she wants all the tools. So we're going to go all in at the beginning. And so we take care of some pretty complicated cases like that, that have, their former gastric bypass patients and all that. And honestly, like I've managed weight all of my time in practice, and nothing really has been as effective as what we're doing now as far as helping people get to where they want to be. And regardless of age, really, it's been really fascinating.
Gotcha. Anything you want to add to this subject, Dr. Garner, that we didn't touch on?
No, I just want to emphasize, I think it's really important to talk with your doctor and make sure that you really are insistent. I mean, we're big on that with testosterone and all these sort of things, and I think that's fantastic because it's important. But make sure your insulin level's checked. Make sure that you understand what your triglyceride to HDL ratio is. Make sure that you are on top of that stuff, because honestly, you that's the thing that kills most all Americans and people really in the developed world. And if you don't go after that, you're going to really miss the boat. And you really haven't optimized if you haven't optimized your insulin level.
Gotcha. So guys, takeaways from this, if all you this is primarily a TRT type channel, but all of you that are saying I got my protocol dialed in, look into insulin resistance, as you're saying, check that ratio of the triglycerides, don't get so obsessed with blood sugars, as you were saying, maybe fasting insulin, thyroid optimization. We're going to be doing a video about that next week. Get that diet dialed in. So, your hormones, your insulin, your thyroid diet. Don't just say, I'm just going to take testosterone and that's it. Because a lot of you're just so focused on this testosterone thing and just really ignoring everything else. Very, very good points here brought up by Dr. Garner. Dr. Garner, again, it's Mercy Aurora Clinic.
Right. Yeah, Mercy Aurora Clinic. Yep.
And that's in Illinois.
It's in Missouri. Yeah, there's so many Auroras, it's hard to keep track. There's Illinois, there's Colorado. Yeah, so we're southwest of Springfield.
It's just a stupid Canadian. I get them wrong sometimes.
All right.
How would people go about reaching you if they wanted to look into some of the stuff you spoke about?
Yeah, so to reach me through the Facebook group, obviously you can do that. That'd be great. You could call my office if you wanted to try and set something up appointment-wise. The phone number is 417-678-5176. And we'll try to get things done for you. I don't do telemedicine right now, but we have quite a few guys that have come to see us. We can make it work, with some periodic visits, and we have an electronic portal that we use and stuff like that.
Cool. Guys, if you're wondering what he means by the group, we have a Facebook group with the same title as the YouTube channel, TRT and Hormone Optimization. Any of you can just click join, get in. There's a number of doctors there, including Brad Garner. A lot of people posting some really interesting topics. I've learned a ton of stuff just being in that group and seeing some of the topics that get posted and the answers that get posted. A lot of the stuff that the doctors chime in on that I thought was one way, and then they correct me and say, no, it works like this. It's a really great learning tool for those of you that are, kind of like type A personalities that really want to know all the details, learn about everything. And again, we're going to keep putting out videos like this all the time. So like the video, click subscribe, click that notification bell so you won't miss anything. We're going to keep producing these videos as long as we're seeing interest here. So Dr. Garner, thank you again for your time. It was really great. Finally, we got an insulin resistance video done. We have one in all the videos we've done so far. So
good. I think it's important, and hopefully it's helpful for guys.
Awesome. I really appreciate the time. Thank you very much.
All right. Thanks.